not social distancing. This is social closening, and we are going to keep in mind some of the topics that I like to support, and specifically keep in mind that this is the dignity of the craft, which we'll talk about later on. I was going to see if Pierre was going to get on because we have kind of an interesting thing to talk about along those lines. I've got a iPhone Dr. I. Who is iPhone Dr. I? Anybody know who that is? Like, I need to know who's on the line. I got a, can anybody tell me who Dr. I is? iPhone?
Probably an ophthalmologist, Paul.
Okay, yeah, probably so.
Yeah.
Hey, how can you get away with Hong Kong? What are you doing there? You got the, right?
Good pickup. I just kind of traveling around.
I thought so. Did you just come back from Wuhan?
Miramonte surrounded by jellyfish, man of war. I mean, come on.
Okay. All right. So I know 718 is. That's Glenn. Good to see it. Who's area code 337? Or it says 133. Any chances that, who's 337?
That's Chuck Burnell.
It is. Okay, got it. Thank you then. All righty. So I think,
Paul,
yeah, and we still don't know who iPhone Dr. I is, huh? Okay. All righty. Well, let's get on with it then. So again, this is the meeting of the jurisdictional medical directors of the 50 to 60 largest cities of the United States and their counterparts, usually from Europe and elsewhere. And but glad to have you all together discuss things that are going on between us. Well, one of the first things I want to do is just, we have kind of a usual week, either weekly or twice weekly report from Amal Matu as our cardiology watchdog. And Amal, there's some new stuff that came out, I think, just this morning. If you have that for us, if you can talk about that. And
yes,
Professor and Vice Chair of Research from the University of Maryland, Dr. Amal Matu. Okay.
Thanks, everyone. Yeah, just a quick report. There's a small retrospective study that was recently published from the folks in New York, where they looked at about 105 patients who had confirmed COVID who were admitted. And specifically, it was an ultrasound study where they were looking at right ventricular distension. Now, in these patients, there is no difference in the number of patients on or off anticoagulation or the number of patients with or without PEs. But interestingly, what they found is that the patients that had ultrasound evidence of right ventricular distension were more likely to end up during the hospital course of needing to be intubated. And also they had a higher mortality, 41% versus about 13%. So, and again, it wasn't associated with PE necessarily. So it's kind of a, it's a retrospective study, it's preliminary, but it is interesting in that some people have suggested that maybe COVID in some way is increasing the propensity to right ventricular distension, strain, pulmonary hypertension also. Why is it affecting the right ventricle more? They also found no difference in terms of left ventricular function or size, just the right ventricle. So that's about it, but it is an interesting ultrasound study that is bringing up questions about whether there is an association between the COVID and some subclinical evidence of pulmonary hypertension in these patients.
And this is not a unique finding, because there's another separate study that was published a couple of weeks ago out of China as well. So there's a couple of people sort of seeing some of the same issues. They may present it in different ways, but they're sort of seeing the same, let's say, pathophysiology going on. And the interesting issue is that it's associated with it. So.
Yeah, I mean, and people are continuing to look for predictors of adverse outcomes and mortality at the time of admission. People have brought up D-dimer, people have brought up troponin. There's another study that talked about troponin at time of admission as a predictor of adverse outcome. We briefly talked about that. So this may be another thing that we should be looking at the time of admission for these patients that predict a worse hospital course and need for intubation, and also increased mortality as well.
And again, it could be a surrogate marker for the issue of the coagulopathy that's very subtle, as opposed to the respiratory symptoms being very overt. The coagulopathy issue is a little bit more subtle and sublime, hitting people. So, okay. Well, thanks.
Right.
That's great. Thanks for keeping us up to date on what's the latest in that realm. I really do appreciate it. Okay. So,
Thanks, Paul.
all right. Let's see. There was a couple other people that I wanted to catch on. And then anything new from New York? Let's go ahead and bring Glenn on, if you don't mind, Glenn. think I saw you there before. Yeah, there you are.
Oh, yeah, sorry, I just unmute.
Yeah.
Again, we are continuing to de-escalate. Our volume still continues to be about 25% below normal. Our cardiac arrests have come back to pre-COVID, but considering that we're down 25% in our call volume, technically it's still a little bit higher. So we're now looking at different things. New York State, parts of New York State have reopened. Beaches are supposed to open this coming Friday, but New York City, our mayor has said that we just don't have enough beach space to really open up. There have been some gatherings of groups of more than 100 people that NYPD has been going out. They were taking down people not wearing masks and such, so they've stopped that a little bit. It just doesn't look so good for us to tackle somebody to the ground for a mask. But things are still continuing to de-escalate, and we're trying to get back to normal. Our national ambulance contract, every day we're starting to thank them, and they're starting to leave our system. As of May 28th, that will be the final. That'll be when the NAC contract ambulances, when the contract ends. So it'll be back to only our 911 ambulances.
Glenn, I was talking to your neighbor recently this morning, and they said they opened the beaches. They were not going to let people go in the water, or they're going to pull them out. What's the rationale on that one? Because they don't have lifeguards around, or what's happening there? What's that about? Do you know?
Yeah, it's interesting because with what the lifeguards are doing normally, kind of sitting up on top watching and patrolling the beaches, looking for swimmers in distress. I think you can do the social distancing, you can have the mask on and such. But the question becomes that during a rescue, if you have to go into the water to get somebody, it becomes very, very difficult. And I mentioned in an email that I sent out yesterday, responding to Jim, that they're looking at us as EMS medical directors and such to say, hey, what do you guys think? And I didn't even think about the lifeguard. The everyday stuff is fine. Even the person that collapses at a pool, by the concession stand, if the concession stand is open, they can take some precautions. But once they have to go into the water for the rescue, if they're completely drowned, then their respiratory status is not great. They're not coughing on you and things like that. But most of them are so panicky that they'll climb on you face to face and breathe on you. I mean, I don't know what kind of protection you can offer, but maybe for that reason, I'm not sure.
That's interesting. Well, give them my best if you see them, okay? So take care.
Yeah, that's true.
All right. Hey, Libby Char, since you're responsible for those lifeguards out there, have you taken similar thoughts about that, or have you had any plans, or is that something that you need to be looking at?
So in Hawaii, the beaches remained open. Even though the beaches were closed, people couldn't sit on the beach. We allowed it for exercise. People could go into the water. The lifeguards were really afraid at first. We pulled them off the beaches, and then we just had roving patrols trying to go in trucks, and we had the jet skis in the water and whatnot. So they're back up on the beaches. We figured that in Hawaii, most of the people, if you're going to go to the beach, you probably, our disease burden was low. And we figured if you were symptomatic with COVID, you probably wouldn't be at the beach.
Well, I hope so. We'll see how that goes, right? But you guys have been doing a good job of quarantining anybody coming in, being the island nation of Honolulu. So that would be, of Hawaii. So that's great. Hey, by the way, when people do come in and they get quarantined, are they kept to one island, or can they go to a different island, or how's that work? Just out of curiosity.
Well, right now they canceled most of the flights. So most of the flights coming in are going to end up on Oahu.
Okay, got it. Okay. All right. Well, let's move on to the next topic of choice. One thing we might go over quickly is Tom Collins's report from his longitudinal serological survey. First of all, tell us what methodology you were using, Tom, and where you are in the game so far. Particularly if you could tell us what manufacturer you were using and how you were doing it.
So we took members of Cleveland EMS and Cleveland Fire volunteers that elected to participate in this 3-week study. They had both nasal swab, PCR, and then epitope testing for IgG and IgM. So of the 291 initial participants, 19 of them had one of the positive tests. We detected 4 people via PCR who were completely asymptomatic, and the remainder had either positive IgG or IgM. And of those, half never had any symptoms.
Yeah.
So, so this is a, you know, we're still looking at the data. This is a volunteer group, and we're assuming that the people within both divisions that actually had a positive test already and were sick and sought care did not participate in the study. So it was largely a group that was asymptomatic to begin with.
Okay. And then let's talk this afternoon because I want to go into this a little bit. You're using, is Epitope the manufacturer?
Yes.
Okay, got it. I just didn't know if that was a specific type of test or if it's the manufacturer, it's the brand that you're using. So I do want to, I'll talk to you later on because we're finding some interesting things that we go through. We don't, again, in the end, we don't know what it means that you have antibodies or not. You know, maybe it means you had COVID or you had some other cross reactivity. Hopefully it is going to be COVID-19 that we're talking about, but we're finding some interesting trends. And then Meg, do you mind if we mention the stuff that you and I were talking about the other day, Meg Marino, or is it premature?
We can chat about it, but it might be a little premature, but we can talk about it.
Well, let me just put it this way. We want people to kind of look for this thing if they're doing this kind of testing. And I talked to Angus about it, et cetera. And Angus Jameson, who's getting ready to do I think, a very good job of following cases with ELISA follow-up as well. But in any event, one of the things we did a sort of a test because one of the brands, which is Celex, was it was only approved by the FDA to use it with a vena puncture. But you know, that's a little bit more painful, so to speak, literally, I guess, than maybe not, you know, depending on your individual, than a finger stick. But it was certainly a lot easier to do a finger stick, et cetera. And so we did a comparison for them on behalf of the state. And what we found was that there was a really good correlation between the venipuncture and, I mean, extremely good in terms of the whole profile of IgG, IgM. You know, one might say mild IgM, strong IgG. One might be a strong IgG and, you know, or, you know, mild IgG. But they were exactly duplicate across both the venipuncture and the finger stick in 97, 98% of the cases. So that was interesting. This was only a group of 70 initially as a pilot test that we did. One interesting thing that did come up is that of the 21, we looked at 21 people who were PCR positive in the past, and of the 21 positive, it turned out, I'm sorry, 31 positive, okay? There were 31 that were positive in the past in terms of PCR and over the previous month or two. What we found in that grouping was that there were 10 people who were not antibody positive, even though they had been PCR positive. So it was interesting. They didn't generate any antibodies, or we didn't detect any, whatever it might have been. And then when we looked at the other 21 were positive to some extent, mostly IgG, and that was straightforward. It's what we assumed we would find. So it was interesting because that group that was positive IgM and positive for PCR in the past were exactly the same age group and, let's say, male, female mix as the others who were coming in who were, let's say, no previous PCR positivity, no previous symptoms. And that group of 40, by the way, was no antibodies whatsoever. So it was we later followed up with 700 cases, and there was only about 9 people that turned positive in that sort of asymptomatic, not previously tested group. So that wasn't a major surprise. What was interesting was that there was 30% of the group had not generated any antibodies, even though they had been PCR positive. But there was a difference. They were, and this is statistically significant, even though there was only 10 in that group, it was statistically significant that they were younger. When we compared that continuous variable of age, they were like 34, 35 years old versus 45 years old for everybody else that we had tested. So it was an interesting signal. I'm not sure how to interpret it. Does it mean that, well, the test is not that sensitive, or does it mean people just don't develop antibodies, or if you're younger, you don't do it, or did you do it transiently, then it went away because you recovered early? And so it just was an interesting finding. But in talking to Meg Marino, Meg, you found kind of the same thing, right? You had a smaller group that you looked at, and only 5 in that would come into that area. So there wasn't any statistical significance yet. But what was the trend that you're starting to see there?
So we were doing some informal testing to evaluate whether or not that a particular test would be useful in our setting of emergency, like EMS providers who had tested positive, to see if the test would be useful for us. And in that very informal testing, we found that of the 17 people who tested positive for PCR for COVID, we had 11 of those had either IgG or IgM or both, and 5 of those, even though they were PCR positive, had no IgM or IgG on the testing. We found that of those 5 people, they were more likely to have had mild disease, more recent illness, and were more likely to be younger. So the mean age between the 2 groups had a 10-year age difference. And so we've only had 17 tests performed. That was all of our employees who tested positive for PCR for COVID. But we're going to continue to look and see what we find. Hopefully we won't have any more employees who test positive, but this is certainly interesting, especially since it is in line with what Paul found.
Yeah, and that's what I think I wanted to bring out, is that, one, we used a different manufacturer, a different test. Again, they were chromatography tests, but by the same token, it was a different manufacturer, and yet we found the same trend, about a 10-year difference. They had that same. So we're bringing this up largely because we're not ready for peer review quite yet, but what's interesting is that there are other studies that have been shown this in Korea, as John Ju has pointed out to us in the past. And what's more interesting is I just wanted to bring that up so that I could reinforce to the group people like, like Tom or like Angus Jameson, who are looking at this to sort of, when you do your breakdown, do some stratifications and see if you're seeing the same signal come up there. And that may be an interesting finding that we can actually, as a group, can even report at some point in time. So anyways, that was it. And so thank you very much. And then in the meantime, anybody have any questions about that or any other thing to add to it? Okay, so if not, let me move on. And then I see that Stefan Polacek is checking in with us from Berlin. And what's going on in Berlin? Have you guys cured COVID over there? Stefan, are you there, or do you have to get off?
Yeah, I'm there, Paul. Do you hear me?
Yeah, I can hear you. Yeah, go ahead.
I'm not sure if it's technical working, so and if you can also see me. So there's nothing special new in Berlin. We had a release of the shutdown 3 weeks ago now. We have some demonstrations and so on and so on, and we are very carefully still ongoing. We have the rate of COVID positive firefighters was 0 for 4 days ago, and now we have a new outbreak on a station with 3 cases at the moment. 1 is in the hospital, so we are feeling at the moment that it's not this easy, that there's nothing is gone, so that we are still in the situation, and then we'll look what's happened now. And it's the first time that we now starting testing for asymptomatic colleagues. So in the first time, they had also the strategy to only make tests with symptoms, because there were no test capacities. And now today we are starting to make the whole station, firefighter station, and make 60 PCR testing today. And we will, I'm very interested what's going on, and I will report this, how many positive cases we found in the fire station. So that's the one main count at the moment.
All right, well, that's very helpful. That I really appreciate you plugging us in on that one, and just glad. Is that you right there? I can't. Yeah, there you are. So good to see you. You're looking good. So
there's my 10-year-old is going now out of the room. Sorry.
A boy, girl, or your 10-year-old?
Yeah.
Okay, go. What's his name?
Anton.
Anton. Okay, good. Tell him we said hi. Okay. All right. Thank you so much. Well, great. Thanks for the great job you're doing over there, and keep us abreast. I hope you do well. I really appreciate you getting on with us today on all that. And it's still light out there, huh? So that's good. Good for you. It's getting be summertime. So I'm glad you enjoy
Great.
it.
And we are reopening now the beer gardens too. So that's I'm unfortunately I can't invite you in the beer garden, but sometimes all of you.
Well, we'll catch up sometime soon. All right. Well, thank you very much. Hey, CJ Winkler, are you there?
I'm here, Paul.
Okay, good. Am I bothering you? Are you okay?
I have 3 kids in elementary school, and my wife works for HEB.
Yeah.
So I'm pulling double duty constantly.
Got it. Okay, got it. Hey, well, I did want to take advantage of this time to let everybody know I don't know if we've sent it out or not, but I will to the group, is that CJ produced a very nice monograph that is going out, it'll be in an international production here pretty soon. It's been sent out already to 300 scientists around the world, and will be further, I think, deployed to many other thousands by September or so. And this is a monograph on the pre-hospital resuscitation with low titer O-positive whole blood by civilian EMS teams and the rationale and evolving strategies for use that he and Jim Roach from Broward Sheriff's Office were able to produce and relay their experience in the civilian setting. And if you don't mind, I thought, CJ, can you give us an update on how things are progressing along with your use of whole blood in the field? Any new data for us yet?
Yeah, Paul. So the data we have ready for publication is that, unsurprisingly, shock index is lowered or improved, if you will. Blood pressure is raised, improved. As far as mortality and morbidity and those kind of things, we finally got that data, are getting that data this week. You would think it would be easy. I wish we had Pennsylvania's trauma registry at time, but we don't. So that took a large lift, a year-long lift to happen. So that information should be out. I will say that my research colleague is, he's a rather conservative in his estimates on whether we're actually improving mortality. I think he's a little more bullish on if we're increasing time to death, which I think we can probably prove. But beyond that, it's all up in the air.
Yeah,
I do know it's the right product.
Yeah.
That's all the things we want to do.
Well, that's good. Well, I mean, yeah, absolutely. From many points of view, it sounds like it's the right product. But I just wanted to congratulate you again for leading this thing, and you and Jim Roach doing such a good job in getting international recognition. Really appreciate it. So thanks a lot. Okay. So, and good luck with the pulling the double duty there. I really appreciate it. Hey, David Miramani, is anything you would add to what his comments were?
No, even though we've been distracted by COVID, our trauma stuff is still rolling right along. And so it's good that we're still giving blood product. That really doesn't change that much. But I think it's the right direction. The whole thing, again, is it's not the product. It's the system of using the product that is most important. You have to generate your own blood product locally. You have to have a coalition of O-positive low titer donors. You have to have a relationship with the blood bank in your trauma centers. And you have to have hospitals that'll burn the blood that's after the 14-day limit on the EMS agency so you don't waste blood. Again, you could buy blood and throw it down the drain, but that's not an ethical use of such an important product. So you have to develop a system of care for blood administration. That's so important. And what it does then is it just force multiplies your resources when using whole blood in the pre-hospital community, and then it's used in the local non-trauma center ERs, and then in the ER itself. So it rises all boats with the tide by giving good patient care to patients in multiple venues by having such a system. So it really is important to really work with your blood center, work with your trauma centers and your non-trauma centers so that the blood can be utilized effectively without waste.
Okay. Well, thank you so much. And just great to hear about a topic that's not COVID as well, by the way. So thank you again. All right. So, hey, one thing I did forget, Angus, I don't know if you want to pipe in or not, but do you want to talk a little bit about what you're doing and why what you're doing is a little different from the other antibody testing that's going on? And again, I don't know what it all is going to end up meaning in the end, except to maybe give us an idea of maybe how much the virus permeated our population and particularly our first responders. But you may have a little bit better insight in terms of some specificity issues in terms of the way you're going to do your test. Can you talk about that now?
Sure. So we're using the ChemBio test, which is manufactured up on Long Island, and it's the only one that's currently EUA'd for capillary blood point of care use. It is an IgG and IgM product. We're going to be validating the IgG versus an ELISA in the lab. So we'll be taking a capillary sample and a venipuncture sample from our volunteers. And the IgM, if anybody turns positive with IgM, we'll do a nasopharyngeal swab and run a PCR. That's our asymptomatic arm. We're also going to do a second arm where we're going to take 30 known positive COVID patients from the hospital and do IgG and IgM on them. Also, hopefully looking at date of onset of symptoms versus when the blood was collected to see if we can, one, make sure that the test gives us some positives where it's indicated, and two, see what the time course potentially of mounting that antibody response is.
Yeah.
If that all works out, we will push it out further into the community for not only first responders, but potentially also for doing seroprevalence samples.
Good. And then you and I have talked about looking for a signal like we talked about, which was the paradox that say that the younger people had less antibodies. You tend to think of elderly people being the ones that don't crank out as much antibody. And yet it looks like it probably has more to do the surrogate variable is how sick you got. And maybe the younger people are a better host or not. Let's say they're not good hosts for the virus and kick it out pretty early, and so therefore don't mount it. So it'll be kind of interesting to see what you find. And also I like the idea that you're looking at the correlation between the finger stick and then the what's in the blood test as well. I didn't see there would be much difference there on the venipuncture versus the finger stick personally, and I think the thing we did showed that, but I really want to see more about specificity, et cetera, as you're doing. So I applaud what you're doing. So let's stay in touch. Thanks for keep us abreast. Okay. So, all right. So let's go on. Hey, Ed, Rock, if you don't mind, can you give us a report from the global world of global medical response? Okay.
I can indeed. Good morning, afternoon to everyone. Actually, things clipping along as we've talked about before. Our volume declines overall are pretty much the same. A lot of weather-related issues, obviously, on the air side of the house. Our number of, we use an electronic symptom reporting tool for our providers, and the number of our providers that are reporting new symptoms is declining. Again, knock on wood, a good sign. And we have no hospitalized employees currently, which is good. And I want to do two really nice things. Glenn, I want to tell you on behalf of all of the ambulance contract, FDNY, your staff have been so good to outside entities in treating them as colleagues, answering questions. Alternate destinations have been a challenge, but hats off. You have treated the rest of the EMS community beautifully, and from all of them, we appreciate it more than you know. And the only other.
And I wanted to, hey, and Ed, I wanted to, just to reinforce that, because I don't think any other team, I mean, there are some, but a few others were as, stressed as they were, and so to have that kind of attitude, professionalism in the midst of the ongoing, London bombings, that's what I make the analogy to, was just really phenomenal. So yeah, thank you very much, Glenn. Go ahead, Brad.
And I was just going to say, all of us on these webinars and Eagles, for all of our careers in Eagles, have talked about it doesn't matter if you're fire-based, you're non-governmental, you're private, you're from the East Coast, you're from the West Coast, your volunteer career. It really came together in New York, Glenn, and it really, it's heartwarming to see the community come together like that. So hats off. And the only other good news, and I didn't even know this was going to happen, two of our providers got married on Good Morning America this morning that were deployed in New York. So it's a little bit of good news in really hard times. And I think the message there is all of us need to laugh and some good news, because there's not a hell of a lot of it out there. So as much as we can get out really helps.
Yeah, that's great. I think it was in Times Square. There's ample space, so that was great. And really, thank you guys, everybody. Thanks so much for the support.
We appreciate it.
I hear that wedding had a nice ring to it. Is that right? Thanks. It was for you. I had to. Hey, just so you know, just to keep, I haven't checked this morning to see if the CIDRAP report had come out yet, but there was, now that we've been talking about testing, Mike Osterholm had, I was hoping he was going to get on, had promised us, an update on, I'm going to actually check and see if it's there right now. I had an update on testing, actually, is what they were going to probably do. And I didn't see it. We were hoping to have it, and it's still not out today. I don't see it quite yet. So, but they did put out one, if I can hold this thing up, I don't know if you can see it or not, but if you do go to CIDRAP, CIDRAP, they did last week put out this effective COVID-19 crisis communication for those who are interested in, communicating in a crisis, and just keep that in the back of your head. I'd like to move on to a subject that came up, but well, first of all, let's get a report from Jim Augustine on what's happening on the IAFF and IFC side of things, speaking of which, and then also a little bit about, and then follow that up maybe with Eagles reports that we've had, one of which that'll help us segue into that question that Garth Gamer brought up to all of us out of Phoenix. Go ahead.
Thanks. The issues before IFC, and Mike McAvoy is on as well and can speak to some of this also. They're very concerned as we move into wildland fire season, how they're going to run the camps. So they've done a lot of work with public health to try to set up better systems for managing the camps and honoring distancing and using masks even when they're together. So for those of you who are affected by wildland fires, I want you to know the IFC has gone way out of their way to begin to prepare for that. Some of that planning is also moving across into the hurricane and a little bit the tornado preparedness and how to manage shelters and how to have personnel that are working together and some of it under FEMA contracts still be able to maintain a little bit of safety. Those and then the PPE issues. And our PPE is likely to improve coming into the fall. The IAFF is very concerned that in the big scheme, fire EMS is a third priority in distribution of PPE. Hospitals and congregate care facilities are first and second in some order. They really believe public safety should be first. And I've been viewed as anti-establishment because I believe all three should be first and that we should work collectively on improved availability of PPE. But just so you're aware, your unions are moving to really improve the availability of PPE and one prioritization to move up. And yet locally and at the state level, the congregate care and hospitals are still a priority. Want all the medical directors to know that's an issue. Drug shortages. I sent you all the report last night. 102 preparations still short. Those are cardiac drugs, epi, the EpiPens, lidocaine. I have no lidocaine in any of our boxes. Toradol, ketamine, all of your favorite drugs. Some of the injectable paralytics are going to come short now and into the future because as we move back into elective surgeries and procedures, there'll be more competition for paralytics and sedative agents. Bicarb is not available, and we're beginning to get into problems with IV fluids. And then a really stupid one, again, I remind you with your hospital hats on, fluorescein strips not available.
Huh.
The pharmacists at the hospital don't know what mutual aid is. And so we had to educate them that we could share these very important little strips. Don't make any emergency physician or patient go without an eye exam with fluorescein when you can exchange those things amongst the hospitals and make sure that there are good supplies. That's the start of the report before we get into the hospital issue. Paula, anything else you want me to cover?
No, that's fine. But I will like stop and maybe Andy Garrett, since you're over at HHS, just I hope you could take that message back and maybe at least put it on the radar screen. That would be helpful. Okay. And anything from your end, by the way, Andy?
Hey, Paul. No major updates since Friday. The pediatric MIS-C syndrome continues to be of high interest right now too, as the more we look, the more we seem to be finding. So interagency's cool enough to take a look at that, and there are 2 pediatricians, myself included, from ASPA that are going to be part of the interagency process for this. So more to come. I'll keep you posted. But right now, I think the highest priority is probably enumerating what things look like in the pediatric ICUs, but then also appreciating there's probably a spectrum of illness here that's not purely critical care based as well. So I think the issue about pediatrics and COVID still is evolving here. So we'll have to see what.
I think the fascinating thing is maybe because the kids can't tell you they're sick or don't know they're sick or whatever, and then it shows up a couple weeks later. We've always thought that the prodrome was always there, and people may not have known they were having it. Then they get sicker a week and a half later. And this is sort of analogous to that, but it seems to be a little further out and a little bit more protracted. So it's an interesting pathophysiology here. But it's been interesting anyways with kids in general not getting it as high an attack rate as everybody else. So
yeah, or at least not being terribly symptomatic with it, which
yeah.
sets us up to not necessarily know to look for it in somebody who might have been sick and we didn't even know it. So
that will bring up a good point.
There.
Yeah, maybe they're more asymptomatic carriers among the kids, and we're just not testing them, and that brings up issues about the school openings and blah blah blah, et cetera. That'll be interesting. Okay, thanks for keeping us.
One more update just from ASPR, just for folks that might have known. Kevin Yeske retired last week as the Principal Deputy Assistant Secretary at ASPR. This was his second post-uniform services tour through HHS. So there's an acting Chris Hessel, who's in place now, and I'll keep you posted on other administrative leadership changes there. But that's a big hit for us.
Yeah, give Kim and Bob a shout for me. Thank you so much for letting me know. Okay, so let's go to the hospital issue then. So who do you want to lead this off, Jim, and introduce Garth from, because he was one that raised the issue. Go ahead.
Yeah, so everybody who responded, and if any more of you want to respond, would be great. Garth Gamer from Phoenix was asked to contribute to the discussion where hospital systems wanted to designate facilities either hot or cold or green or red, however you want to do that. You all responded to begin with, and then it got into a lengthier discussion. Garth, you want to talk about how it applied locally and what you did with the input from the Eagles?
Yeah, sure. I appreciate everyone's input on this, and I'm sorry to bring the issue up and clutter everybody's life with it. But I was approached by a C-suite representative of one of the major hospital chains, and I chair the local regional the regional EMS council here that if you're going to come up with a triage scheme that's different than the normal state of affairs, then that is the go-to group. So she posed this question to me that they wanted to identify a couple of facilities that they would designate as clean facilities, and then attempt to get all the EMS traffic that was suspicious for COVID to a center of excellence in COVID treatment down the road. Well, there was a lot of local factors here that caused me to immediately kind of protest this this sort of arrangement. The two facilities they wanted to identify as clean facilities were adjacent facilities and would have resulted in a 20 to 25 minute transport time down the road to the red facility that they wanted to designate. So it didn't make a lot of sense locally, but it brought up the question, well, should we have this sort of triage to begin with? And I just wanted to query the group to see if there was any sort of impetus for me to go forward with this in the Phoenix metropolitan area. My initial thoughts were that this couldn't possibly take place because of the varied presentations of COVID. You know, a lot of patients would be in extremis with their COVID, and we couldn't expect EMS to go 20 minutes down the road with somebody who was an active code or near code. I thought the best way these facilities could handle this would be aggressive point of care testing, but and then with secondary transport. But as doctors Rock, Clemency, Holly are probably aware of the system here in the Phoenix metro area, GMR is one of the major players, and there's another player that they're both pretty much overburdened with the interfacility transports the way it is. There's a big interfacility flow of traffic here in the Phoenix metro area. So I didn't want to create more problems than I solved here in the Phoenix metro area. So that was my background. I took it to you folks, got great input, kind of solidified my feelings on this, that it was more an intra-chain issue than an EMS issue. But as you astutely brought up, James, that this is something that we just can't discount as flapdoodle here. I think we need to sort of study this and see if there's a set of criteria for instituting something like this. Like if transport time is only lengthened by 10 minutes, then you can consider this. It would require a paradigm shift by in all EMS systems, I think. But we, as you also pointed out, we've been down this road before. So with that, I haven't heard back from the chain, by the way. I think that I squelched their forward momentum on this, but you know, I could hear back from them later today as well. So
let me ask Glenn Aceda, since you are in kind of a unique situation, and maybe there was actually appropriate attempts maybe there to actually do such a thing. Can you discuss that from your perspective, where you really got hammered? I don't know if you can still hear me, Glenn, or you just got to unmute.
Sorry, yep, I'm unmuted. Yeah, you know, everything for us just came too late. You know, if things are pre-planned and you have potentially, you know, we want to keep the hospitals clean, so to speak, absolutely. But everything kind of came in when we were in the middle of everything. And, you know, hospitals would start claiming that, oh, we're only taking COVID, or we're not taking COVID. And, you know, and it was community acquired, community spread. It was too late. I mean, it was just the ones that said, oh, we're only taking COVID. I was happy to say, well, then at this point, you're getting everybody, because everybody's potentially a COVID positive patient. You know, it's very different. I know Jim put out a great discussion and things, and, you know, with trauma centers, burn centers and such, you can see it. There's a mechanism of injury type thing we can figure out, and those specially designated hospitals are great. When you can't see things, you know, like even influenza, if we try to have an influenza-only hospital, it's, especially when it's community acquired, it's just impossible. I think the planning, though, you know, like I said in an email I sent yesterday, every update that you see now with politicians, you have some medical person there, right? And EMS is being looked at as leaders and such. And although this may not be an EMS direct issue, you know, we're the ones bringing them to the hospital, and short of having an instantaneous test that we can do in the ambulance to determine, yes, they're COVID positive or not, it's almost impossible because we can't see what's going on. And, you know, we got so overwhelmed. As I said, our volume is usually 4,200, went up to 6,500 for a good 2-week span, that hospitals were asking for 8 hours of total diversion. And that was just not possible. Had there been clean hospitals, I think even with that volume, we wouldn't be able to take all these patients to even, you know, we have 60 or so non-receiving hospitals. If we designated 30 as COVID, they would be very overwhelmed. And it wasn't just that, you know, I had one hospital, 175 patients admitted, 90 to be seen, you know, 12 nurses called in sick for the night shift. I mean, they were running out of vents. They were running out of staff. I mean, everybody needed a timeout, but it wasn't possible. And, you know, to tell somebody that, oh, it just can't be done is not a response that we'll give anyone, and it's not appropriate. I just don't know how we would do it, even with pre-planning at some point with something like COVID that you can't see, that ultimately everybody is assumed positive. You know, again, maybe for the next wave that people are talking about, we can start planning. I still don't know how, but for us, it didn't work because everything came in the midst of things, and we just could not accommodate at that point. Maybe if we do it early, we can plan it. I just don't know how. Even the Ebola centers, you know, we still have Ebola designated hospitals. We had one case officially in New York City, luckily. Had this been like the COVID spread now and such, I mean, luckily it's not as transmissible, we would be in much worsened state. So I don't know. I don't know how we could do this.
Yeah, I got it. Yeah, I think that's the general feeling out there. Let me ask the group, anybody else want to weigh in on this or anything else to say? I mean, I can close the subject out, but it just make sure that I, you know, have brought up, I mean, everybody saw our email exchange, but anybody else want to weigh in or make a comment about this?
So it's Mayor Montes. So I think it's a good idea for systems to designate a hospital for their admitted patients. And the reason why is they can cohort staff members, PPE, and processes, especially in our area. For example, 2 of the systems built specific units. They converted ICUs with additional features to make it easier to take care of COVID patients with negative pressure, with special slits in the door for the vents and have the vents outside the rooms, and the holes in the wall for the IV pumps, that kind of stuff. So I think it makes sense to cohort admitted patients within a hospital system, but I just don't think it's possible to do that from EMS unless we have rapid testing in the back of the truck, which is not going to happen anytime soon. Right. But for admitted patients and ICU patients, it makes sense because then you're exposing a specific cohort of nurses and physicians and keeping the rest open for surgeries.
Yeah, we just need one of those COVID sniffing dogs out there in the back of each unit, right? So we'll see how it goes. All right. So anybody?
Paul, it's Jim. Of course, I'm gonna present that we really should press this issue, and I think this is great use of resources. Now, there are 2 assumptions. One is that we have testing available that is rapid and sensitive and specific. Number 2, we're not in overwhelming circumstances. I think a fall outbreak, we need to look smart and be smart in the healthcare system, and trying to keep open other parts of the healthcare system that we're going to start to see the death penalty in, from people not having their elective work done, not having their screens done, et cetera. In a lot of cities that I serve, there's 2 systems that do all the hospitals. And they want to go out of the way to designate hot and cold places, not make us look bad in EMS by not transporting to the correct place to begin with. But as we do in strokes, trauma, and everything else, we are very sensitive and specific, but not perfect. And I don't think they would call on us to be perfect. And it's much better use of our healthcare resources. And I have no problems as an EMS leader to be involved in leading this discussion. and saying we, if possible, and if there are systems that want to designate, as Dave is saying, and as John Gallagher, who I don't think is on the call, did in Wichita, I think this is incredibly smart and effective, and it makes our healthcare system work better, and it allows areas of expertise to be built on both sides of the track with clean or dirty. So I urge you all to at least think it through, know how it applies to your system, have good conversations with your hospital systems who, like mine, are trying to pay the bills through the fall months. And we give them the opportunity to do that by more effectively working with them to use our hospital resources.
And then what goes on with your caveats are there are always going to be walk-ins as well, so that you can't necessarily control. So how are you going to handle that part? So just there's a lot more goes into this than meets the eye. All right. Anybody else want to bring anything else about that before I go on to the next topic? If not, I did want to just, while you had Mike McAvoy on the phone, Mike, anything else you want to bring in from the IFC end, since you're the chair of the EMS committee there? And also, as far as the airway issue, I think we're going to address that on Friday. Okay.
Okay. No, I think Jim Augustine covered the bases very well, so I don't have anything else to add into that.
And then George Hatch, Executive Director of COAMPS, anything else new and evolving and percolating since your talk with us several weeks ago? Sorry to catch you off,
no, Paul.
Yeah.
Oops. No, I think I'm off mute. No, yeah, I think I think most of the schools are still wrestling with how is it that they're going to be able to open? How are they going to be able to teach? They're front loading, as we saw before. They're front loading all of their didactic information, but it really comes down to access for laboratory practice, and then are they going to be able to get access to clinical sites and to field sites? So I think around the education world, we're still going to be trying to figure out how are they going to open for school in the fall, if that's going to happen. So no, I really don't have anything else to report.
And then the balancing pressures are that if we do see, people either leaving the job or just the need for the workforce, there may be just regular attrition, let alone people retiring. And that's kind of an issue. On the other hand, then we also are concerned that since revenues are down, namely taxes or sales tax or state income taxes or whatever, that you actually may see a cut in the workforce. So I hope that's not the case, but it'll be interesting to see how this balances out. Okay. So then I just saw Dave Pearce was able to get on. I hope you can join us, Dave. Dave is not only the medical director for the nation's 4th largest city and therefore a high input zone, so to speak, but also the health director for the city of Houston. And Dave, anything new coming on from your end, especially as a, being a person of the public health ilk?
Sorry, I'm joining so late, and sorry I'm not on these regularly. Because things like this happen.
We actually had an official gag order on you previously, but it's okay now. We're opening up the state.
I'll call them back later. So the only thing is that, we here in Houston, our numbers have been fairly flat. That's in terms of hospitalization and also the number of folks who are testing positive. The governor in Texas, as some of you may have known, has been pretty aggressive in quote unquote reopening the economy. And we're all kind of holding our breath. And actually this morning, for the first time, I'm starting to see the numbers start to creep up a little bit in terms of hospitalization. It may just be that I'm, Dr. Scaredy Pants right now. They may go down tomorrow, but we now have just a couple of days of very gentle increase in our numbers. And so I'm holding my breath. Lots of things with testing that are, sampling and testing and going on. And it's all a bit of a mess right now. We've got the federal government doing things, the state government's doing things, the local government's trying to do things, and there's no bad actor really, but things are moving so fast that there is a fair amount of left hand, right hand, not knowing what's going on with the other, which is making it confusing. People are keeping their cools about it though for right now, so that's good. But how about that?
How's your coordination? Do you have good communication and coordination with the other health directors in the state, particularly Harris County and?
So we do. Good question, Paul. So the health directors, the public health authorities for Montgomery, Harris County, Fort Bend County, City, Houston, and then a couple of municipalities like Sugar Land and a couple of others. We talk twice a week at a 7:30 morning call, and we're finding out that's working really well. It's kind of like this call where we're sharing our problems and also sharing solutions. Probably most importantly, we're making sure that we have a similar philosophy about how we're approaching things.
Yeah.
Because each our environments is a little bit different, but our philosophies are aligned, and that's good now. And that's been real helpful.
Yeah. So, it's incredibly important too that the people get a message, because I think one of the problems with this crisis, just in general, nationwide, is that there are so many different messages and and the implications from different things that it's really good to have someone. And what's great about having you there is that you understand EMS as well and can basically help voice those needs as well and make it part of the solution, actually. So thank you for the great job you're doing as usual. So I was thinking you're approaching almost a quarter century at the job. You're going to get into the pretty soon. Like when was it? Like July or something of '96? I can't remember. When did you come in?
Fall of '96. So
yeah. So you
when I get 25 years, does my hair grow back?
Yeah, it does. Yeah, right. So you're at a double dozen right now. So hopefully we'll move you on to the baker's dozen. So thank you so much then for what you're doing, David. Anything else you want to bring up from your end, though?
No, I'm all ears. I want to hear what y'all are talking about.
Yeah. Okay. Good. So let's move out to John Jew just to make sure I've caught up with him and see if there's anything else new going in the infectious disease realm or anything else new to report from that end, let alone Portland.
Hey, Paul, thanks. There's actually only two things. Everybody's probably heard the Moderna vaccine announcement yesterday,
yes.
The phase 1 results. I think what's important is to know who the authors are, and they're probably that's from the NIH, and the fact that they are looking for neutralizing antibodies. So that's pretty promising, but we'll have to watch a little bit more. The other thing was I just saw, this is in regards to Meg's comment, I just read a abstract that actually looks at the antibody responses between adult and children. And the children's antibody response was markedly different than the adult, where the adult had primarily IgG and IgM, and the kids had a markedly lower level and primarily IgM. So, and as everybody here knows, the children are much less affected than the older adults. So that's sort of interesting, and it probably matches a little bit with your with Meg's data here as well as the Korean data. We're actually in a plateau right now, and watching everybody else to see if there's a spike as well. That's about it.
Okay, good. Thanks for giving us that. So since we're on the West Coast, let's jump down to Chris. Haven't heard from you for a while. Then I'm going to come to Mark Gautreaux next. So be prepared, Mark. And then, Chris Kahn, what's happening in San Diego? Anything new to report from down there?
No, things have been actually pretty much status quo for a while. The biggest issue that we are trying to sort out is the fact that we've got probably about 250,000 American expats living just south of the border, about 20 miles south of where I am right now.
Yeah.
And we know that the rates of cases and fatalities are starting to increase, especially in the Tijuana region. So we are starting to see a few more calls at the border, especially compared to the overall volume of people crossing the border, which is down a bit. Normally it's around 100,000 a day, and it's probably down in the 65,000 range now. So we've actually been having some of our folks from local health systems working south of the border to try to shore up their capacity for ICU management and that sort of thing. Part of the issue we noticed down there is that their older doctors are not permitted to work. So we find that that means a lot of the specialists they're not allowed in the hospitals anymore. So we find a lot of younger folks who may not have quite as much experience are the ones trying to manage these very complex ventilator issues and that sort of stuff. So that's the big thing on our radar right now. California looks like it may be starting to do a little bit more reopening in the next week or so, and
we'll see how it goes.
Okay, well, thank you then for the report. Really appreciate it. So let's go up the coast a little bit. Any chance you can get on with us, Mark? Are you there still? Mark Gautreaux from
Yep, I'm right here.
Yeah, go ahead, Mark.
So yeah, we are doing pretty well up here in Santa Clara County in the Bay Area. We are just entering phase 2 of our opening up plan with curbside pickup at retail, but no in-store shopping yet. In terms of our response agencies, we are going to be actually launching a big antibody study in the next week or so with all 1,400 firefighters in Santa Clara County, and then looking to expand that to law enforcement in phase 2 of that. We're working on identifying funding for that now. So it'd be interesting once we start generating that data. It's interesting working through all of the legal issues with conducting studies on city property and things like that. That's one of my big tasks today. So
it's the usual. Thank God for the lawyers, right? So it's good.
My big concern is watching the caseloads. Is we are, we're way down on the bottom end of the curve with just maybe anywhere from single digits to maybe a couple dozen cases in a county of 2 million people reported daily. And interestingly, the cases are not at all evenly distributed. So San Jose typically has about 3 times as many cases per 100,000 population, about 150 per 100,000 population, where neighboring Cupertino is down at 44 per 100,000. And we're thinking a lot of that has to do with just density of households with multiple generations in a single household in the eastern parts of San Jose versus the more single family dwellings in some of the other areas. But interestingly enough, the wealthiest part of the county is the second highest concentration, and that's in Palo Alto.
Yeah.
We think that may actually be skewed due to a much higher rate of testing in Palo Alto
right.
than in the county. So
yeah, so the always issue is like, what's the rate of hospitalization and or deaths is the thing I tend to monitor, although they lag behind.
right.
So that's interesting. Yeah, that year maybe, I think you're right. It may be that. So, and that's what makes this whole thing kind of a little squirrely, because they're doing more testing now, and then it's hard to know. All right. Well, anything else then, Mark? Thanks for your good
No,
work.
just we're very happy that our death rate is we're hitting 0 deaths in multiple days now. So
good. Good. Hope it stays that way. And as Mike Osterholm was predicting a couple of weeks ago, was that he really didn't sound like he was expecting it until June, if not early to late June, before we start to hear what's going to be on. Okay, so. So anyways, hey, so while we're at it, I just want to jump ahead because I hadn't heard from Paul Adams. Are you there, Paul, by any chance today? Because I think I didn't see your name on the list, but I think you're telling me you're on. Are you there by any chance, Paul Adams?
Yes, Paul, how are you?
Yeah, good. I'm so glad to hear from you. I've been wanting to hear from you. For some reason, I can't identify you on the list, but I've been wanting to hear from you. So go ahead. Tell us what's the latest in Miami, okay? So.
Well, we're kind of actually in phase 1. Actually began on Monday, so things are opening up, and we had a marked elevation in cases because our governor decided to empty out all the ALFs and nursing homes with anybody who was positive and take them to the hospital. So that caused a little bit of confusion with our numbers, and our one number we were tracking was the amount of hospitalized patients, and so that number was corrupted. And then, of course, all these people, the first thing when they went to the hospital, when they already had a positive test, was get another test, and so that spiked all the tests. So that was kind of an interesting week last week.
Yeah.
Now those people are being transferred back to the nursing home.
Yeah, okay, got it. So that's so like, well, whatever. Welcome to the real world, right? So, in any event.
Yeah, I'll be interested to find out what the new IgM test has to say, as we've tested Celix and multiple other, up to 10 other brands, and have had very poor success. So I'll be very interested to see where that goes.
So let's talk about that, because I got to see what you mean by poor success, but let's do that offline. And I think that would be a real interesting thing based on some of the things we talked about earlier today. and we're seeing evolve with this thing. So, okay, and then it's just great to have you online, Paul, and let's talk about that. And same with Mark Gautreaux. Let's get together as these data evolve. I just want to see if we can make some sense of it or come up with some kind of at least signal here as we go through this that maybe, hopefully hypothesis generating. All right, I do want to jump over to Milano. If you're on, Dr. Roberto Fumagalli is not only at the head of the ICU in the emergency department, their main trauma center there, but also the head of the emergency medical services for Milan. And Roberto's here again. Professor Fumagalli, you there? Let's see if I can get him to hear me. I see him online here. See if he can plug in with us, or maybe he's just monitoring it. Or, oh, there he is.
Do you hear me? Do you hear me?
Yeah. Buonasera. Buonasera. Okay.
Buonasera.
Yeah.
Well, here things are. This is the second day after the lockdown off, and right now we are not admitting. Let's say we are admitting a couple of patients positive for COVID, but with mild respiratory disease. Up to now, let's say the last patient we admitted to the ICU is 10 days ago. And we still have, let's say, 12 patients with some of them are really quite old. Let's say that we admitted them 40 days ago.
Huh.
Most of them, let's say a couple of them are really sticky and I think they are not going to improve anymore. And the other are slowly improving.
Yeah.
So
have you guys used any of the plasma by any chance, or any of those infusions, etc.?
No.
Harvested. Okay.
We did not give the hyperimmune plasma to them. We didn't, and actually they did all became negative to RNA negative.
Ah, okay, got it. All right, and then what's happening with the EMS? What's happening with the group?
We are using it as a marker for the disease. Let's say that the number of calls are really quite steady. Let's say we have around between 6 to 10 calls per day for, let's say, respiratory problems.
Yeah, okay.
So, it's very constant, and we are getting it like an alarm to see if something is changing.
Okay. So how about your number of injury cases? Are the motor vehicle collisions or trauma going up at all for you?
Let's say that they are still in the low number, the low average, but they are increasing. Let's say that they increased a little bit last week because we have the first week where we restarted some works, and but up to now, let's say they are below the average. Absolutely.
Okay, interesting then. All right, good. Anybody, by the way, does anybody else have any questions for Professor Fumagalli? Okay, while he's on the line, I didn't know if you have any questions to ask of him. And just so while we're waiting for anybody to pipe in, I was going to say we may have a discussion on Friday a little bit about airway provision and so on, and how aggressive to be about intubating people. And I think you guys learned to be a little bit more conservative about intubating people early on, correct? Is that true? Did you evolve that way?
Yeah, let's say that it was really very different in different regions, in the different areas of Lombardia. I think that in the area of Bergamo and Brescia, they had really much more dramatic situations.
Okay.
Let's say that they tried not to admit some patient to the hospital because the hospital were really overcrowded.
Oh, okay.
So it happened that the EMS had to intubate at home some patients just because they got very, very sick at home.
Got it. All right. That's a different situation. That's interesting then. All right. Well, that's good. Anybody else have any other things they wanted to ask him? If not, I'll move on. This is great. It's fantastic way of seeing you. And I owe you something by tomorrow night, I hope. Okay. So
Dr. Fumagalli,
yes.
It's Jim Augustine. Two things. Have you seen the pediatric, this inflammatory syndrome? And what are you doing about antibody testing in the country? Because if you're making use of it, you've been a little further ahead than the United States.
Let's say that we have really few pediatric cases, really few. Actually, the antibody screening is ongoing. And actually, I'm not aware of informations about pediatric populations. So I'm sorry, but I cannot add more information about that.
Oh, that's fine. But we'd be anxious to hear whatever does evolve later on. Let us keep us informed about that. Okay, I'm going to go visit some other people on the line. Scott, you don't have to say anything, Scott Nichols, but if you have anything to report on or don't feel obliged at all, I just thought since I saw you there, I thought I'd plug you in. If not, he may not be hearing me, so that's okay.
Okay.
Thanks, Roberto. Okay, so fantastic. Let's see. Let's take a couple of reports from around the country. Crawford, anything new in Philadelphia while we're on the east, on the Atlantic side of things?
Similar experience to everyone else. Volume's still down. Fortunately, the number of our exposed employees is markedly decreased. Hospital volume's still a little bit down, and slowly but surely we're starting to open up again. But other than that, nothing else.
Okay, Chuck, Burnell, anything to report since we didn't get a report from you last time? Anything new?
Yeah, so Texas is, can you hear me, Pepe?
Yep, I can, sir.
Okay. So Texas numbers are going up, they think, due to increased testing. Louisiana's flat going down. Hospitals are getting about, ones I visited with, about 5% recovery. We're doing the little phase one, phase in. EMS volumes are actually probably up about 10% across our coverage areas. That's 911 call volume. And other than that, number of employees has gone down markedly. I think we're getting smarter with the PPE and a lot of these things. So we've had very low numbers on employee exposures over the last month. And that's about it, Pepe.
Yeah. Okay, good. And I was going to see if Emily is still on. Anything to add, Emily? Is she there still? Maybe she's off now. I'll let her know. I was looking for her later if you had a chance, Chuck. But Chuck, tell me again, you got Acadian, which covers large number of ambulance services across mostly Louisiana and Texas, et cetera. And how many paramedics total are you responsible for?
A little over 3,000. And we're doing a lot of industrial work also, Pepe, along the Gulf Coast, Florida, and pretty much Alabama all the way through on the industrial side. And we're using a lot of those paramedics to do that right now while business is slow. So that's actually helped offset, you know, furloughing and that type of thing.
Mm-hmm. Okay, got it. Just, yeah. Then that's any particular impact there or anything of note regarding that industry?
Yeah, the biggest thing is we're doing, for oil field companies, to shut down an asset for one day is between $3 and $5 million of lost revenue.
Wow.
So these guys are doing aggressive testing. We're doing 5-day testing parameters for them where we do a PCR and antibody testing on days 1, and then we do 3 and 5 an antibody test. And I'd mentioned the test that we had best luck with being the CellX and the API was one of them, or AB Abacus, I can't farm API. And then the third one was the, I'm drawing a blank on the bio when I sent out the other day. I'll tell you though, those tests, I've been validating 2 or 3 different tests for other companies.
Yeah.
And I have been very, very underwhelmed at the, because of the inaccuracy of those other tests. And we have no need to move from the other tests unless we just cannot get them. But I will tell you, there are a lot of bad tests out there that we've come across.
Yeah, and that's what
I've
that's what we've always thought. So that's interesting. So, but that's why I do want to see with what we do have to see if there's any trends there and try to get a better handle on it, since so many people are using them and coming up with the information. I want to stay ahead of that curve instead of just saying, well, they're lousy, because, you know, we'll see how that goes. All right, well, thanks. Let's go talk to some other folks. Rob, are you up to talking? Rob Lowe, are you there out of Columbus, Ohio?
I'm here. I'm doing well.
Oh, that's so good. Good news for us all. So it's good. You're out there at day, geez, you must be close to day 12 right now, right? So you should be.
Yeah, I am. I'm day 12.
And you got better over the weekend, right? So.
Haven't had a fever for about 48 hours now.
Yep.
So
Okay.
small chance I make it back to work this week.
Okay, got it. Well, don't rush. We're just glad you're doing well. Anything new to report from Columbus? What's happening in your realm?
We're kind of steady state. We're like most of you in kind of the phased reopening pieces. Been fairly lucky, although there's a few reports. For the most part, people are fairly compliant. And so we haven't had too many of these standoffs with large gatherings or anything like that. So progressing.
Okay, good. All right, well, glad. Just first of all, just great to hear you, and thank you for hanging in there and being here with us as well today. Let's see who I'd like to tap on. Let's just jump down to Austin real quick. Jeff Hayes, anything new happened in the center of the storm there?
All normal here, Doc. Everything's good for now.
Okay, fantastic then. All right, and then let's see, Lakshmi, what's happening in Atlanta? If you're there, you probably just
yes.
There you are. Good to see you.
Yes.
Now, first of all, this is most important.
We're doing good. Numbers are creeping up.
Hang on for a second. Who's that with you there? Who is that with you?
Oh gosh, my video's on. I'm sorry.
No, it's okay. No, it's great. We want to know.
This is my youngest, my 3-year-old.
And what's her name?
Ahana.
Ahana, great. Welcome. All right, go ahead. Sorry to interrupt you. We just like to know everybody.
Yeah. No, our numbers are creeping up. And I worked this weekend in the ER. It was a welcome change to see STEMIs and strokes. It was a lot of everything else. But not as much of a spike of COVID as I would expect, I guess, which I'm not complaining about that. It might be the possibility of a lot of places not opening, even though the restrictions are lifted, they're gradually opening. But even in the hospital, our numbers haven't crept up.
Okay, got it. Okay. So that's basically it. Now, when you say the numbers are creeping, is that because it has something to do with opening up things more there, or is it just what you're seeing, or what do you think?
I think so. With the opening up, I think people are getting a lot of the chronic illnesses and non-COVID stuff. They're actually seeking care. We've seen more of our sicklers coming to the ER, people that we see on a normal basis who've been worried about coming in. They're slowly coming in. Okay, got it. All right. Well, thank you very much, and it's great to meet your little one there. So she's so cute. So that's good. She is almost as cute as your mother, right? No, got to be cuter, right? That's good. No, but seriously, both of you, thank you very much. And to bet you, she's just as brilliant too, right? How's she been? Smart kid? She's bossy and sassy.
Okay,
Not
got
like
it.
her mom. Not like the mom.
All right, got it. Okay, well, listen, thanks. Hey, Veer, what's happened over in Fort Worth?
Hey, so we are pretty much the same. We've had our reopening for a little while now. Our hospitalization rates have been pretty steady here for a little bit.
Yeah.
So we are waiting any impending storm that comes, and we've just been working on testing all of our long-term care facilities like the governor asked.
Okay, got it. Stein, what's happening in Colorado Springs? Oh, yeah, I haven't talked to you for a little bit. Oops. Maybe I took him by surprise. Stein, are you there? Or are you muted? We're trying to lift the gag order on you, right? All right, we'll wait to see if he pipes in later on. That's fine. All right, then let's see if I can talk to Mark Conrado. We talked to you last time. Anything new since last week, Mark? And again, probably in mute land, right? Okay. Hey, by the way, while I'm waiting to see if either Mark Carnarado or Stein Bronsky get on the line, it's EMS week this week, I found out. Is that true? Anybody know? Can you corroborate that? Is this EMS week? And so I want to thank all those people out there that are doing such a great job and for us on a day-to-day basis. RJ, let me then go over to you since you're across the river.
Not much new except the governor, just like in Fort Worth and other places, suddenly mandated all nursing homes to be tested. He wants 10 nursing homes per day tested.
Okay, got it. And who's going to do that, by the way?
They called out the National Guard again.
Okay, interesting. All righty. So and then what are you expecting to find? That there are going to be a lot of positive cases, or what's the implications for you?
Yeah, we do. We think there are probably some fomites in the nursing homes. We've had to evacuate one in Minneapolis and another one the National Guard is in. And in St. Paul, we just had 9 all of a sudden. We think there are some fomites out there amongst the staffs.
Okay, got it. Joe Holly, are you still there? Your improved version?
I am indeed. We are just moving into phase 2. Our numbers have been steadily increasing, but we haven't seen a big change after our phase 1 opening.
Okay, got it. All right, good. And otherwise, you're doing fine. I'm glad to hear your voice. It really is good. And Stein, I guess you can't get on. It sounds like he's having some type of audio problem. Therefore, we can't hear him. We'll try to see what we can figure out, or maybe you being Mr. Digital, you can figure out about that. And Stein, if you can't hear me, let's talk later today maybe and just get up to date on the website, et cetera, and do some things along those lines. Okay, and then let's see. I'm trying to see if there's anybody else. AJ, do you have anything to say from your end?
Yeah, I'd just like to give a shout out to Mark Eckstein and his guys and our prayers. He has 2 guys on ventilators as precautions for inhalation burns from their ladder escape, and sounds like they did a good job EMS-wise to get everybody out of there quickly.
Yeah, it was phenomenal. I was in touch with them, and it's just amazing that more people didn't get more severely injured as those 2. But I think they're probably going to do okay in the long run. Yeah, thank you for saying that. And I think, let me see if, I think Hillary was on before, but I guess we lost her, so we'll leave it at that. Anybody else have anything they'd like to pipe in and talk about with us? Anybody else out there have a report for us? Well, the timing looks good because it's 11:58. So everybody, thank you so much. 11:58 my time, and I know in your zones, anyways, it's approaching the 90-minute mark. And thank you, everybody, for today. It was a good discussion. I really, really, really enjoyed it, and hope we keep this up. And thanks for bringing along the loved ones as well, people like Dr. Kumar, okay? It was really nice to see everybody and their families and that you're doing well. This has been an important time for me to see everyone being well. And so if you need anything from me, give me a call. And if there's topics that you want to discuss, let me know, okay?
Thanks, Paul.
All right, see you later. Take care.
Everybody.
Okay, welcome back, my friends, to the show that never ends on Friday. See you later.
Yeah,
Thanks, Paul.